afternoon, everyone. I'm Dave Potenziani. I am an adjunct faculty member in the CHIP program, and I'm playing the host for the Health Informatics Seminar Series this term. Welcome to our first one of this year. We have 3 speakers today, but what I would like to do is remind everyone that this session is being recorded. If you have questions, please, or comments, please hold them until we get to the Q&A portion. The way we're going to work it today is just to go ahead and have our 3 speakers give their presentations and then open it up for a Q&A after all 3 have made their presentations. So today we are joined by 3 UNC Health Clinical Informatics Fellows who are leveraging electronic health record technology and evidence-based decision support to transform clinical workflows, improve depression screening and treatment in primary care, and reduce unnecessary emergency department admissions. The 3 speakers are Darius, Byramji, who is a board-certified general pediatrician and first-year clinical informatics fellow. He completed his residency training at UNC and then spent 4 years in outpatient practice at Wake Med, where he served as the pediatric physician champion for Epic implementation and AI governance. Dr. Alex Fenn is an emergency medicine physician with clinical informatics expertise. He completed medical school at Duke University, our good friends in Durham, and his emergency medicine residency at UNC, where he developed critical care billing best practice advisory. Dr. Noah Schwarz is a psychiatrist and clinical informatics fellow here at UNC. He completed medical school at University of California, San Francisco, and psychiatric residency at UNC, serving as chief resident. So we will begin with Dr. Byramji.
Okay. And everyone can hear me okay?
Yes.
Okay, well, thank you very much for the introduction, Dave, and thank you so much, everyone, for having us. My goal for today is to highlight a few projects and initiatives I've been able to contribute to in my role as a first-year fellow in regard to EHR and physician workflow efficiency. Kind of how Dave alluded to, it so happens that my desire to become more efficient myself with Epic after training and help my colleagues do so is what pushed me to come back to fellowship, despite being out in practice for almost 4 years. So I'm pleased to be able to share how being a clinical informatics fellow has allowed me to do just that in the short time that I've been in fellowship. For my time with y'all, I'll be talking about some physician builder initiatives I've been able to work on, specifically in building smart text and MyChart questionnaires. And then to close, I'll briefly touch on our opportunity as fellows to contribute to governance for the health system. And then hopefully that acts as a good segue into what Alex and Noah will be talking about. So to start off with the smart text builds that I've been able to do. So generally defined as smart text and Epic are templates that can contain pre-generated text, links, and lists that are specific to a patient's chart. And our pediatric primary care and allergy immunology colleagues had requested that certain paper forms that are usually they have to fill out for patients, that they be embedded and able to be electronically filled out in Epic. And just for some context, the traditional workflow for filling out paper forms in pretty much any clinic setting is the patient brings in or requests the form to be filled out at the time of their visit. Sometimes they may not have the copy, so it needs to be found or printed out from a separate window. Maybe it may not be on your computer. The provider handwrites the information during or after the visit and the actual face-to-face encounter. And then, but a lot of these things that they're filling out are otherwise addressed and available on the chart, so it ends up being double work. And then a copy is manually scanned to the chart. So the goal for making a smart text of these particular forms was to have one-piece workflow within Epic for the provider that eliminates the need for handwriting the information and instructions on the paper form. And that generated copy is automatically saved to the chart for them as well. And for future reference by the patients or even other providers. The specific forms requested were county-specific school administration forms that the school nurse then has on hand for a patient. These would be in English and Spanish, so it's two different forms for the two languages. And then the food allergy action plan, which is a standardized form that a lot of schools or even like daycares ask for if a student needs like EpiPen administration for a food allergy. And that would also be in English and Spanish. So just to provide you guys with some visuals of what these look like, this is a copy of the Wake County Schools medication administration form. And as you can see, it's quite busy and time consuming for the provider to fill out all this information by hand. That is, again, already available or entered in by the provider in the chart. Things like the name, date of birth, the actual medications being taken, telephone numbers, the date, and it's essentially ends up being double documenting between two different mediums. And one of the cardinal sins of clinical workflow, I would think, is double documenting. So want to avoid that at all costs. It looks similar, but this is the one for Durham County. There's some minor nuances and formatting differences, so that's why there was a separate request to build, and it required a separate record. But again, similar busyness, repeat work. And then this is the food allergy action plan. All this information you can see can be discretely pulled from the chart. So again, name, date of birth, their weight, telephone numbers, physician name, even sometimes it asks for like the practice address. And just worth also noting, all of these forms have a back to them that also need to be filled out with additional information. So it's also something that nothing more demoralizing than when you fill out a form and then realize there's a back to it. But again, with the smart text build, we were able to be able to provide both sides of these forms. So now that you have like a visual, how did the form build process actually happen? So we use the already smart links that you have available to you in Epic. Were used to pull in the demographic information and then the encounter and visit specifics. So like date, the provider name, patient's name, date of birth, addresses, telephone numbers, anything that would be requested in that form. And it's automatically put in the correct field. The smart lists were also embedded where appropriate to allow for quick selection of applicable medications and allergens for the patient themselves, or that would be applicable to the patient. And again, this was to aim to reduce like handwriting for the provider even after printing out the form. And you probably saw there were a lot of check boxes on the forms. Not all of them need to be checked, of course, but with the smart text template, the check boxes are actually like interactively like clickable. So again, not something that the provider has to do on the or repeat after printing out. But after printing, the only step outside of the Epic workspace for the provider is just the wet signature. And the value added here was, again, promoting one-piece workflow just within the Epic interface, print, sign, done. And then it, of course, reduces documentation burden and saves time because a lot of, again, these discrete fields that are already there in the chart or already entered maybe during the visit just automatically pull in to the form itself. So moving on to the MyChart questionnaires. So it was a similar situation where a lot of these, there's certain paper forms, again, that would be filled out by the patient or parents. But we tried to make it to where they could be pushed out via MyChart so that they could be electronically filled out and then pulled into the chart. The first form that we did, one of the forms that we did was the RAPS screening form for teen annual visits. It's a one-page screening tool that assesses safety and social history. It's 21 questions in total in a yes/no answer format. And I apologize in advance for not being able to provide a screenshot of it or show a copy. it's proprietary to a third-party company, and the use of it is licensed to like the institution for use, like in the clinic, so not for dissemination. So just wanted to clarify that. But with just this one-page form, instead of having the patients, they would fill it out by a paper copy. The front desk would hand it to them at the time of visit to clinic, and then the answers to those questions would be manually inputted after the patient was room, and usually it was manually inputted by the provider whenever they had a chance, after reviewing it. Could have been right before the visit or after, but it still interferes with workflow. So we built an electronic version that could be filled out via MyChart questionnaire on a clinic kiosk when they're checking in, clinic tablet, or the patient's phone. And then those responses, after they submit them by whichever electronic medium, would automatically flow into Epic for review and refresh in any note type of documentation. So this, again, would allow for the providers to review responses prior to even walking into the room, and eliminates the need for manual input. And the value added here, with it, one of the main pushes was to reduce paper and printer use. And then again, like front desk burden of having to either print or grab the paper copy, hand it to the patient, and then also reduce the documentation burden in the form of manually inputting the responses after they've been answered. And then from a quality care or care quality standpoint, providers can critically think about addressing any concerns that may come up based on the answers to the questions, and have a plan prior to even going into the room to seeing the patient, instead of trying to address on the fly, or think about things as they're talking with the patient. And the next form that we did, and this usually applies to teen visits as well, was the sports physical form. Usually it's 2 pages filled out by a patient and or parent, and it's about 40 questions that they have to answer. And again, this is usually a paper copy by hand. After they answer the questions on those 2 pages, there's 2 pages that are filled out and signed by the provider. These pages actually have already been built in Epic, maybe a couple years back, but it can't be done until the parent or patient fill out their part, or that's not part of the flow. The physician should be reviewing the patient entered questions prior to filling out their part. So you can probably start to see a theme here. It's a form that's traditionally, filled out on paper at the time of the visit to clinic. Sometimes patients aren't even finished with the forms by the end of the visit. New concerns may come up based on the question responses that the patient or parent didn't verbally express. So one of the main goals here was to create the MyChart questionnaire of the first 2 pages that is sent to the patient's MyChart prior to them even coming to the visit, so they can think about the questions like on their own time, appropriately answer them. And then if they submit them even before the day of the visit, a physician can be pre-charting day of or day before and try to identify, is there anything of concern, is there not, and have their questions formulated even before walking into the room. So again, from a value add standpoint, common theme, reduce paper waste. So that's 2 pages eliminated per every teen well visit, multiplied by a number of pediatric clinics that use them. It saves a lot on paper waste. Allows for the providers to review the responses prior to the visit and actually devote visit time to addressing the concerns. And these responses, again, because they're filled out by electronic questionnaire in MyChart, the responses are automatically saved to the chart, and they're retrievable for note documentation and future charting purposes. So similar to the RAP screening form, there's no need for manual input of the patient's responses. So just as a general overarching theme with all of these builds, whether they were the smart texts or these MyChart questionnaires, was to promote one-piece workflow within the Epic interface itself, reduce paper waste where applicable, and then big for physicians and staff in general, reduce documentation burden. And all of this would then allow for the physician or the provider to focus on the actual face-to-face encounter and help promote even wellness and being able to save time and save time for themselves and for the patients, because patients are often waiting for us to handwrite things as well. So just to give you a visual of what the sports physical form looks like, these are the first 2 pages that we're looking to turn into a MyChart questionnaire. This is what the patient and parent would fill out. So again, very, very busy combination of like short answer, yes or no questions, scales. So again, very cumbersome to try to fill out even for the patient or parent, like in the midst of the visit. So the aim for this is to help everyone on each side, patient and provider. And then last but not least, we just wanted to close, take a minute to highlight the opportunity we also have as fellows to participate in governance committees. And this is a fundamental aspect of informatics that I don't think we necessarily take into account when considering informatics fellowship or in our day-to-day practice, but very much affects it. And our fellowship program, along with UNC ISD, they've been very generous and encouraging and facilitating our participation in these committees. It also serves as a nice segue to what my co-fellows, Dr. Fenn and Dr. Schwarz, will be discussing. As one of these committees is the Agile MD Pathways group here at UNC. And in our role, we serve as clinical subject matter experts alongside ISD analysts, other project managers, and other clinical staff for pathways that have been authored for system use by other providers before they're published and live. And as clinical informatics fellows as well, we have individual authorship access within Agile MD, and it gives us the ability to create pathways for our own clinical departments as we have ideas for them. Or even assist other physicians in authoring their own pathways and then guiding it through the governance process itself. So with that, thank you so much for your time. And I'll now hand it off to the good Dr. Alex Fenn.
Great. Thank you, Darius. I appreciate it. Let me go ahead and share my screen. All right. Can everyone see my screen? And it just shows the slides.
Yes.
All right. I see some nodding. Fantastic. Thank you. So, my Darius, I think, really teed us up well for just to kind of discuss like these projects that we have been working on as fellows and thinking about just like why I wanted to give this talk was just to kind of like before I started fellowship, I had some understanding of what clinical informaticians did, but like not a lot. And so I think just like one realm and where we can be beneficial. And so this is just, I know that we have people here from all different institutions, UNC, Duke, ECU, kind of all across the state. But the TLDR of this slide is that UNC has a lot of hospitals. UNC's EHR Epic is the idea of one Epic instance. And so when I log into the UNC Epic, I am using the same Epic at UNC hospitals that you would up in Pardee and Hendersonville or something like that. So again, like why this talk and why when we were approached to be speakers, why I was interested. So I think that and I understand that people in this class are coming from a variety of different backgrounds, but I still think that despite all of our focus in the media on AI in healthcare and like the explosion of open evidence, and now they just released ChatGPT for health, like very few people actually understand what clinical informatics is, even within the medical sphere. I was just at a friend's house this past weekend, met somebody else in medicine who is pretty far along in his residency training, and I was telling him I was an informatics fellow, and he's like, "Oh, like what's that?" like and just had like never heard of it, had no idea. And this is a guy who is now in his fifth year of postgraduate training after 4 years of medical school. So he's been ensconced in the medical field for, I guess, 9 years now, and still had no idea what it was. And so I like to think, and the way that I kind of describe it to the layman is like people who are clinical informaticians from the medical standpoint, meaning that they are physicians and have done a fellowship or were grandfathered in or are board certified, or just bridging the gap between the technical and the non-technical people, and kind of sitting in the intersection of IT, health-related operations, and then taking care and seeing patients. Um, and then the other thing that I just wanted to highlight is just and I think that all of us are doing is just thinking about the different projects that you can work on as a fellow. It was described to me that as a fellow you can kind of take you can take more of a research-based approach, or you could potentially you could take more of a operations versus administrative approach. And I think a lot of us, just due to the strengths of our program and what they are able to get us involved with, have gravitated towards, and also just personal interest, gravitated a lot towards the uh, the operational admin side of things. And so Pathways at UNC is an initiative that I believe coming up on just about probably like a year and a half to 2 years. Is it's using a third-party software that is built on top of Epic, so you can access it right within the EHR. And the idea is that these pathways are algorithms that you can follow to provide more standardized care. Again, the example and showing all of those UNC hospitals, the goal of these pathways is that they can display up in Hendersonville, in Asheville, in UNC Nash, and at the medical center, and that we are providing the same care to patients at all of these UNC sites. So I like to think about when I am thinking about these pathways and these algorithms, um, don't know. I don't know everyone's background, and if everyone has been and has heard of just the concept of clinical decision support. And so clinical decision support has been around for a while now. It can look like a lot of different things within the electronic health record, though general principles are that you should consist of the five rights of clinical decision support. And so that is getting people the right information. So in this case, we would think about specific algorithms and guidelines to the right people. Are we targeting providers? Are we targeting nurses? Are we targeting administrative staff in the right format? This, in this case, is going to look like a specific pathway, but are you going to build in some sort of pop-up in the right channel? Where does it fit into my workflow? Am I building out a pop-up, and am I interrupting somebody? Am I just recommending it based on a chief complaint? And then again at the right time. So in order to really consider the utilization of clinical decision support, I find that you really have to think about these, and this is a core principle of informatics and something that I think about probably on a daily basis, whether I want to or not, as I am building out some of these tools. So, as mentioned, these pathways at UNC, I am know that there are a multitude of third-party vendors out there that essentially just kind of sit on top of Epic. Essentially, the way that Epic works, I believe it used to be called the App Playground. I think now it's called Showroom. It's essentially Epic's kind of third. You get access to Epic's API if you agree to play nice with Epic, and essentially can build on top of Epic. And so this is a clinical decision support tool. Hopefully, we are using all of the five rights of clinical decision support, and integrates directly into Epic at UNC, recommends specific orders and protocols, drives, and is the goal is to drive evidence-informed decisions. Things that you can do within a pathway is you can place orders from the EHR directly in the pathway. You can integrate some clinical calculators, and you can link to different Epic order sets, and also outside PDFs, things along those lines. I apologize. I have a screenshot of some generic. Again, the Agile MD is something that is considered, at least proprietary within UNC, so slightly limited as to what we could show. But I like to think of it as essentially like if you've used something like a Figma, or even just any sort of like MBA business type practices where you're looking at just specific diagrams is I think they're overall very intuitive to follow. So specifically one that I think has had a lot of impact from a clinical standpoint is this ED chest pain pathway. And again, I like this pathway because I think it takes it the end goal that we are able to do is divert admissions from the hospital and provide patient with follow-up care via an informatics, and part of this implementation is via an informatics lens. So um, as mentioned, like I work in the emergency department, and essentially, like previously, like there are basically two dispositions from the emergency department. And when you say disposition, is somebody comes to the emergency department, are they just going to be able to go home? Are they going to be able to be discharged? Or are they going to have to be admitted? Are they sick enough to have to come into the hospital? However, medicine is frequently a little bit more of an art than a science, and there are a lot of patients that operate within this gray zone of bucket, specifically these moderate acuity patients. And so this might be somebody that says, hey, I don't know if they need to I don't know if they need to be admitted, but I also don't feel really safe with them going home. And the problem is if I don't feel safe sending somebody home, that's like the bulk of my decision. That's like the meat of what I do in the emergency department. And so that's a really difficult decision. And so the default prior had really been to admit these people. And when you're admitting people into the hospital, at the end of the day, that is costly and not the best resource utilization. And so in terms of these moderate acuity patients, what was developed at UNC was these alternative care pathways. And so we said, hey, we've got this list of patients that are in the gray zone. They are not a slam dunk go home or slam dunk come into the hospital, but we don't necessarily know what to do with them. How is it that we can build out a way in which they're being seen more quickly in the outpatient setting and ensuring that they have adequate follow-up, essentially so somebody can lay eyes on them? And so a lot of this is background health system and putting forward the resources and building things that are potentially really outside of the informatics locus of control, like setting up these cardiology clinics. And so there were a lot of discussions that were had on the back end about how do we do this, but essentially UNC cardiology agreed that for some of these specific conditions that they would be willing to set up these clinics or hold spots in these clinics for patients to be able to follow up within 48 to 72 hours. But then the issue comes into how do we risk stratify and how do we figure out exactly which one of these patients is appropriate for this clinic. And that is where informatics comes in and building out these pathways within Agile MD. And so the idea is that, as mentioned, trying to avoid inappropriate admissions and get these patients able to, these potentially high risk patients or moderate risk patients to a more rapid follow-up. And then increase the documentation of the heart score in physician notes. And so the heart score is a if somebody comes into the emergency department with chest pain, one of the risk stratification tools that we use is the heart score. This is just an acronym. This is a clinically validated scoring tool that looks at the patient's history, the EKG, their age, their risk factors, and a troponin, which is a measure of any damage to the heart. Basically, what you do is you then score that all up and give the patient kind of put the patient into buckets as to whether they're low, moderate, or high risk for a serious cardiac event. What is cool is that within Agile MD, previously there is not really a very intuitive way to be able to uh, to document this in Epic. It involved clicking around a lot. But what is cool is within Agile MD is you actually are able to, we've actually now built out a calculator. And so essentially when you're looking at this pathway, I'm going to show you an example pathway, you can essentially just click and you'll be able to just input that hard score. Um, this is again, this is an example of what a pathway looks like. This is one of the demo pathways on the Agile MD site. And so really what it is it's just kind of you're just following these boxes, these little flow charts, and you're saying, hey, like, is an alternative more likely? Do I actually think this is the specific diagnoses? And so this one is an example of heart failure, but something similar for recommended workup for chest pain and whatnot. And then another thing that we were able to build out, again, thinking about these uh, just these alternative care pathways and the five rights of clinical decision support is how do you want to let the provider know that they can access this? And so what you can do is you can essentially create these rules in Epic and say, hey, like this patient's coming in with chest pain, they're an adult, maybe they have a past history of heart disease or something along those lines, and then you can put a little an indicator of how you want to alert the provider. We've decided no one in that is working with an Epic likes the what are called interruptive the OPAs, interruptive BPAs, which are pop-ups. Everyone much prefers the ones that aren't actually alerting you. And so this is an OPA in the storyboard, which is just like a little flag on the side that's like, hey, maybe you could consider the chest pain pathway if you want. Again, just kind of thinking about how we get that to the people in the right at the right time. And so at the end of the day, the goal is that we're essentially building out this process using informatics to divert admissions and be able to get these appointments within 20 minutes. There is an order that is embedded into these pathways that just allows patients, just allows providers to place a referral. We then are directed to secure chat with some of our unit secretaries and be able to get a follow-up with cardiologists typically within 72 hours. And so that is really remarkable, and patients are really grateful for that. And it's also just better healthcare utilization in general. So again, all coming back, I think about this like all the time, and these five rights. And so in terms of this pathway is you have when you're thinking about the right time, you are presenting this pathway and this recommended clinical framework upon presentation to the emergency department after a chief complaint of chest pain is inputted. The channel is already integrated within the Epic EHR, so just kind of in the ecosystem that we're all using. And in the format, it is the clinical this sport is institutional knowledge about knowing that these pathways are there and that these are clinically validated. You're providing it. You're in terms of the people, your ED providers are the ones that are meant to use this, whether that's attendings, residents, or APPs. And then the information is again these guidelines, these risk stratifications for the heart score, and then institutional specific policies about how we could potentially divert admissions. So that is just a little dive into the pathway that one of the pathways that I've helped develop. And so now I will pass it off to Dr. Schwartz.
Thanks, Alex. Do you all see my full presentation, or is it in presenter mode?
We can see the presentation slides. It's fine.
Perfect. Well, thanks again for having us, and thanks, David, for the introduction. Again, I'm Noah Schwarz. I'm a psychiatrist and a fellow in clinical informatics with Darius and Alex. I'm going to share with you all a clinical informatics approach to treating depression in adult primary care. And I'm going to focus on two things in particular: clinical decision support that we've been talking about this whole hour, and then quality metrics. And before I get into it, I just want to acknowledge that most of this work has actually been done by my colleagues in the UNC Primary Care Improvement Collaborative. So they deserve a shout out for their excellent work on this. I have no conflicts of interest. So why does this matter? Depression is a major cause of disability and suffering, and treating depression works. It reduces disability, it lowers healthcare utilization and cost. And to no one's surprise, depression is very common in primary care, in adult primary care. About 1 in 8 adult primary care patients in the United States have major depressive disorder. And most antidepressant prescriptions are actually written by primary care providers, not by psychiatrists or mental health specialists. And UNC is no exception to this. Our primary care providers manage tens of thousands of adult patients with major depressive disorder. But there are a few challenges in managing this, in particular in primary care and at UNC specifically. The first one is that a lot is changing. The evidence for treating major depressive disorder is changing faster than the practice guidelines can keep up. At UNC, we have an expanding network of different clinical resources for depression management in primary care, things like consultation, collaborative care, psychotherapy, other interventions. But those resources are different in different clinics, departments, entities. So, for example, UNC Family Medicine in Chapel Hill has different resources than the UNC Primary Care Clinic in Western North Carolina. And because of that, it's hard for clinicians to connect their patients to the right depression resources in their clinics. And then finally, and I'll say more about this in a minute, the reporting that we do for quality measures is changing. In particular, a trend towards something called an electronic clinical quality measure, which I'll talk about. And that has major implications for value-based payments from the federal government on the order of sometimes millions of dollars. So that's the first challenge. Everything's changing. The second challenge is that the clinical decision support we have right now for managing depression in primary care is variable and it's decentralized. So there are treatment algorithms and order sets that are different in different clinics, different specialty departments, and different entities. And some of that clinical decision support is out of date with best practices. But it's very hard to update all of that to keep pace with the evidence when it's so decentralized. So that's the second challenge. And the third, which I alluded to before, is that there's a requirement for structured documentation of some of these quality measures. The Centers for Medicare and Medicaid Services publishes and maintains something called clinical quality measures, which are just standardized tools for measuring how a healthcare system is doing in managing different kinds of health conditions. So diabetes, hypertension, heart failure, and the government uses those and healthcare systems use them for quality improvement and reporting, but also, as I mentioned earlier, for reimbursement for certain value-based contracts. And for big health systems, those reimbursements and meeting those quality metrics can make the difference of truly millions of dollars across their contracts. And importantly, for our purposes, an electronic clinical quality measure has certain requirements that are different from a standard quality measure. And it's that the data sent to CMS have to be structured and discrete, and they have to go directly to CMS. So our reimbursement analysts can't extract the data themselves and summarize and report it. It has to be transmitted directly from our database. We're taking two different approaches to these problems at UNC. I'll talk about the first as our practice advisory and the second as a pathway that Alex already discussed before. One more thing about the clinical quality measures and depression. So the measure for depression is pretty simple. It just requires that patients aged 12 and above once a year be screened for depression, and those who screen positive get a follow-up plan documented. But as I mentioned, for this electronic clinical quality measure, that follow-up plan has to be discretely documented. But mental health documentation in psychiatry and also primary care is mostly unstructured. It's mostly free text narrative notes about what the patient is experiencing and what the clinician is doing to help them. And so right now at UNC and most healthcare systems, the way that we document our depression follow-up plans don't meet these electronic clinical quality measures. This is just an example of how CMS determines how someone's performing these measures. So they calculate the denominator, which is the number of patients who should be included in this metric, who should be getting this evidence-based care. And then they calculate the numerator, which is how many patients are actually getting that care. And that percentage is compared against a metric and a benchmark, and reimbursement is based on that. So the first solution at UNC, which is the work of my colleagues at the UNC Primary Care Improvement Collaborative, is something called an R Practice Advisory, or an OPA. OPAs are Epic's way of telling clinicians that they need to take a particular action. And the solution developed in this case for depression is a way of generating that structured documentation in a single click for the primary care providers treating depressed patients. The way it works is that the rule is running, the OPA is running rules in the background constantly on patients. And as Alex mentioned, it can screen on a variety of different factors. So it identifies patients who have a certain age, who screen positive for depression, who don't have certain exclusions. And then when all those criteria are met, it fires or it appears as an alert to the provider. Importantly, at first it fires unobtrusively. So it's on the side of the screen, the clinician can see it, but they continue their work. But if the clinician tries to close the chart, they try to see another patient without addressing the OPA, it's a hard stop. It stops the clinician from doing that. And as Alex mentioned, that is a very aggressive, disruptive form of clinical decision support and should be used very selectively because it's very annoying to have your workflow disrupted. And more importantly, it creates something called alert fatigue, where clinicians start ignoring alerts. They try to figure out ways to work around them, and the purpose of the alert is undermined. But in this case, the health system decided that this process, this documentation was so important that it was worth generating this escalating style of OPA that eventually creates a disruptive hard stop if it's not addressed. Once it appears to the clinician and the clinician engages with it, they just click on the follow-up plan that they've decided on, and then that automatically creates in the back end all the structured documentation that CMS needs for its quality measure. So that's the first solution, this alert to the provider, the OPA. But what if the provider doesn't know what their follow-up plan should be? So that's the second solution, which my colleague, co-fellow Shahryar Farooq and I are working on. It's one of the pathways that Alex Fenn was describing. As Alex mentioned, these are EHR-embedded clinical decision support tools. They collect all of the data and order sets that a clinician needs to make decisions and take action in one place. And they can be configured to follow all of those 5 rights of clinical decision support. So for depression, we made a series of algorithms that allow primary care providers to assess and treat patients based on severity and other factors, and provide them with all the data they need to make those decisions. These scores that patients screen on their various depression measures, data about their comorbidities that affect what medications they can be prescribed. For example, some medications, the dose is based on people's kidney function, and so the kidney function values are displayed alongside those medications so the provider can easily make those determinations. And then finally, referral resources, which, as I mentioned, are different across clinics, departments, entities, are displayed to those providers based on where they're located and what the needs of the patient are. This is just a mock-up of what of how the pathway works. As Alex mentioned, we can't show the actual pathways that we have live in UNC, but this is the basic idea. On paper, it just looks like a regular flowchart decision tree, but in real life, many of these elements are dynamic. So they display changing data. They allow the provider to, as Alex mentioned, fill out questionnaires, document, place orders, all the things that a person needs to do in one place. So in summary, UNC Health is developing clinical decision support for depression treatment and quality measures. And this is needed because a lot is changing in the practice of depression treatment, the resources available to us at UNC, and how quality is measured. The current system that we have is variable and decentralized, and the quality measures for reporting and for reimbursement are changing. And the 2 solutions that we have in development are our practice advisory, which cues the clinician into the need for this structured documented plan and allows them to do that in one click. And secondly, a pathway that gives them clinical guidance for whatever follow-up plan they're pursuing that's based on evidence and the policies and resources available at UNC. So there's some references, and that's it. I'm going to stop sharing my screen.
Thank you to all three of you. There has been quite a bit of activity in the chat. I'll just go through these in order. One of our colleagues has asked sort of a question of Dr. Byramji. Are these pathways in use or just developed as a model, and who will maintain them in the long run?
Yeah, I can speak, and I see another question in the chat just kind of about like coordination of the pathway and departmental approval. So in terms of pathway development, partially it is done via if a subject matter expert has an idea. So if there is a physician, this is being kind of talked about at the institutional level. If a physician has an idea, for example, a kidney stone pathway or this chest pain pathway or anything along those lines, they can essentially submit their idea, and then that gets run up the chain to there's a core governance committee that essentially approves that approves the specific pathways, and then it goes through different levels of review, both from the clinical and the technical side. The idea is that these pathways don't just have a unilateral author, but that they have multiple authors from multiple different fields as well as from different entities to make sure as much as possible of UNC is represented. Once the pathways are then developed, they are in use. I want to say UNC has in ED, ambulatory, pediatric, inpatient settings, over 100 pathways that are in use right now and they're continuing to build out. One of the features of the software is that actually you can provide real-time feedback. And so you can say, an example is we had a pathway in the UNC emergency department for deep vein thrombosis, and noticed that we had orders to only lower extremity ultrasounds and not upper extremity ultrasounds. So submitted actually a resident emailed me because they didn't realize there was a feedback button. I said, hey, there's a feedback button, but I'll do it for you this time. I clicked the feedback button, just wrote, hey, we should probably link these other two orders for upper extremity ultrasounds as well to make things easier. One of the authors got back to me within 2 days and said, hey, you want me to add this? Great, like I'll push it next week. And so pretty real-time feedback in that. And then I believe we're not on this long of a time frame yet, but I believe after 2 or 3 years, kind of all pathways are on a review cycle just to make sure that they're being used and if we need to update anything.
First, a comment. Another colleague from Duke says, as someone who practiced as a family practitioner for decades and was a medical director, thank you. Outside documents are one of the banes of my existence. I do believe that is very much heartfelt. But another question that is a theme in the chat is the idea of how do we evaluate these things? Personally, as a recovering academic administrator, how are these approaches, particularly Dr. Byramji's approach of being able to offload some of this effort to other people? Well, the bean counters are going to want to know, how much time has this saved? How many dollars have been cut out of the workflow, so to speak, so that this takes off the plate of that clinician that essentially paperwork.
So, yeah, from a quantitative perspective, I think the initial thoughts are in measuring, like, say, like creating like a paper form into like an electronic version. A lot of it's centered around almost like what even like ambient AI software is. It's more around wellness. Like that's that's the measurement. Do physicians feel like it's beneficial to them in their workflow and that they feel like they've devoted more time to actual like patient care and less time to documentation? As in regard to quantitative measures, we have had I've discussed with some of the higher level, one of my mentors in informatics, maybe actually once, especially once the like the sports physical form is live for the patients and parents to fill out. That's always like the 2 pages that are consistently need to be used for paper. How much money that saves every time 2 pages are printed out for every patient that gets a sports physical, or and measure that over like a period of like a month to 6 months, compared to the prior to the live date of the questionnaire itself. But yeah, that's I know the bean counters would want to know, and maybe qualitative measurements aren't that you can't measure in dollars, but also what you can measure in dollars is physician moral injury and attrition, and how that costs the health system and population.
True, and burnout is an ongoing issue in among physicians and has become worse as we have, at least it's associated with the rise of electronic health records. Okay, another question. This referred to Dr. Fenn's presentation. I sure understand the goal, but how does this project handle the issue of different rates of and risk for illness across different communities across North Carolina? Part of the reason for variation in practice may be undesirable, but some may reflect differences in the underlying population. In theory, and over time, clinical decision support can be adjusted to take into account these variations, but along the way, damage could be done. A particularly striking example is Rocky Mountain spotted fever, which has a very high mortality rate if untreated. North Carolina is a national hotspot, and this malady has both significant variation by season and geography. Sickle cell anemia may be another example. How do we avoid these sorts of cases for now and concentrate on the high prevalence, high risk conditions with less variation?
Yeah, that is a very good point in that yes, you are going to inherently, with the 20 hospitals or 17 hospitals that UNC has, you are inherently going to have a lot of variation in the patient population. I think right now the focus of these pathways, so the pathways, you cannot contextualize them. So the goal is that the pathway is standardized as much as possible across all of the entities. And I think the goal right now is to handle some of the more common chief complaints and common things that people are presenting to the emergency department for. I think once more pathways are built out, you could then think about getting a little bit more granular, and would potentially then have to consider different disclaimers for different areas. I know that as an example, I was looking into an employee needle stick or an occupational health pathway, and I just met with somebody from occupational health yesterday, and that is a whole nother can of worms because that is getting into different UNC owned versus managed entities. And frankly, I don't know exactly what that's going to look like. And that's less from the clinical side of things, but more just from the operational side of things. So I think the software is overall still somewhat new, and there are a lot of things that still are being figured out and determined what best practices are.
Okay. Dr. Schwarz, this is another from the chat. This is a huge problem for practices, patients, and the community. But did you pretest the OPA to see how it worked in practice? Sometimes, despite the best of intentions and plans, implementation comes out differently than intended.
Well said. In this case, yes, my colleagues who developed this OPA did test it extensively because it's anticipated to affect so many providers so frequently. And one of the nice things about OPAs and Epic is that they can be configured at first to run in the background. So they're not actually displaying for anyone who's working, but in the background, they're testing themselves and testing how often they would activate and in what circumstances. And then you can review those cases after the fact without any of the clinical workers ever actually interacting with it. And so you can get a decent sense based on your sample of what's going to happen once you put it into production. But of course, unexpected things arise, and the more you have it out in the wild, the more those cases can happen. But in this case, for something that was expected to affect so many people so frequently, they did do a lot of testing.
So sort of going back to where we started in the questions, how do you track use of this, and how do you think that you're going to use these approaches and have them be adopted across a large health system and perhaps someday beyond?
Yeah, so there's a variety of ways that UNC is tracking. One is just they are able through the software to look at who is essentially clicking on these pathways down to the individual user and seeing, hey, like this pathway got a lot of traction, or this person is using these pathways a lot. And I think from that standpoint, at least, you then can, there's been a really big push just from the provider and really just employee education standpoint. And I think making sure that people, regardless of their technical ability, understand what these pathways are and how we can use them is huge. And having people like us be the clinical champions and disseminating that information has been a really big push. From the patient standpoint, there's a variety of things that we've looked into. I think that something that we have thought about, for example, with the chest pain pathway, is just thinking about the number of not just pathway utilization, but the number of referrals that are actually placed, is then you get into what are the appropriate numerator and denominators of which patients are actually appropriate to go to this clinic. And that gets a little bit more into the weeds with each specific pathway. But people who develop the pathways are really, they tend to be subject matter experts who are really interested. And so I think that a lot of times these iterations tend to come pretty easily.
So it would probably be criminal of me not to bring in an informatics setting the question of artificial intelligence. What you have been developing here and all of this looks like the kinds of systems that long ago we used to call expert systems. But all of these are going to generate a great deal of data as they're used, particularly if they go to scale. Can you see some utility in the future, or perhaps some pitfalls of being able to harvest this kind of metadata of the clinical use and application of these approaches to inform people trying to make these same kinds of decisions or about diagnosis and procedures in the future? I'm just asking you to speculate.
I could imagine a scenario where the data from these pathways are used to train a model along with all the other EHR data, or that these kind of decision rules are fed through some sort of retrieval augmentation to an existing model that's used for clinical decision support. And you're right that these are in some ways an older technology. These are deterministic, static clinical decision support, which has its benefits. It's very clear and reliable and predictable, but it's not adaptable, to some of the circumstances that Dr. Mishner was mentioning about idiosyncratic cases or variations by season or population. So I imagine that soon there will be versions of these that have some fixed rules like this and some guardrails, but also are using artificial intelligence to augment or inform those clinical decision support tools.
Thank you. We're out of time. In the comments and as well as here in person, these were tremendous presentations. Thank you, all three. You have acquitted yourselves very well today.
Thank you for having us.
Thank you so much.
Thanks all.